Good afternoon, good morning. Thank you so much for joining. I'd like to particularly welcome Dr. Susanti, the Director of Non-Communicable Diseases for the Ministry of Health in Indonesia, and Dr. Muharram, who's the Head of Neurovascular Division at the National Brain Centre Hospital, RSPON. And on the UK side, we're really pleased to have early in their morning Dr. John Cooper, who is the clinical head for our collaboration, but he also is consultant at Leeds Teaching Hospitals Trust, postgraduate dean for Yorkshire and the Humber, and other things as well. John, I'll let you carry on there. And particularly to Dr. Deborah Lowe, who's the National Clinical Director for Stroke for NHS England. So that really is exactly the area that we are covering today. She's also a consultant stroke physician herself in the Wirral Hospitals, Teaching Hospital and University Trust. And I'd like to say thank you to everybody who has helped to set this up today and got it all running. We are at the start of a great collaboration on how skills and the whole of the health workforce can be deployed to give better outcomes in the area of stroke. So stroke is a leading cause of death for Indonesians. We think about other things, but actually stroke for people over 5 is the #1 here. But it also causes a huge amount of disability. It affects the quality of life for everybody who suffers a stroke themselves and for the whole of their families, as well as a huge financial burden and the caring. But it's not only here. It's also still a major illness in the UK. It's our 4th cause of death. So one life roughly every 17 minutes. And that's after a major improvement, a really significant improvement of halving the UK death rate from stroke in the last 10 years alone and before that. So I think really we share a determination to achieve better outcomes for everyone in both our countries. We're both reviewing our stroke services, everything from public awareness and prevention to roles for the workforce in the primary settings, access to specialist services in hospitals and through rehabilitation, and at best back into work. So I'm really delighted that we can share information and learning and question and think through what can be done for both sides. This is the beginning of the collaboration. It's the first in a series of webinars, and our speakers today will share the approaches that are taken in the UK and in Indonesia, and it's the start of exchanging these ideas and finding the opportunities for more improvement. Please ask questions. The speakers from both sides here are the experts, the people to talk to about where did we start, why, how, why that care pathway. How do you get training into the primary settings, into all the areas that can really make these big changes? How do you check competence? How do you train? Are there areas where upskilling people into new areas means that you have somebody with the right skills in the right place at the right time to just make that difference for somebody's life? So I really look forward to hearing from both sides of this conversation and to a very active discussion Makasih banyak to everybody, and thank you.
Thanks, Zoe. Really nice introduction there from the Indonesian side. I had just a bit of background, I think, around the background to the sort of work that we were doing with the Indonesian community in stroke. I'm not sure if the slides are ready for that. So as the technical stuff always takes over the world. So yeah, okay. Thank you very much, Claire and Claire, who are on that. So this is just by way of background, which I think is really important, because I think this is a really really good project with two very, very quite different healthcare systems and different communities of practice within stroke, but with a common endpoint, which is stroke itself as a disease. And what we've done over the last 12 months or so, and if we go on to the next slide, this is almost phase 2 of what we're trying to do. So we are in transition in the United Kingdom. NHS England and certainly the departments that we were when we started this project were Health Education England, NHS England. There were other departments, NHS Digital, NHS Improvement, and following a Secretary of State decision to merge all of these so-called arm's length bodies into one arm's length body. We are in fact an arm's length body. That means we are a non-departmental part of the government to deliver the provision of health care within within England. That's what we are in NHS England, and that includes workforce, it includes services, it includes all other enabling functions as well. My directorate is the Workforce Training and Education Directorate, and that's for the strategic planning of workforce, but moreover the training and development of workforce within NHS England. I'm delighted that I'm really grateful to actually the very confusing Claire and Claire collaboration. So Claire Closewell and Claire McIver, who have really done most of the work on this project, who are part of our global health unit as part of the NHS England collaborative, and that sits within the Workforce Training and Education Directorate as well. So I think trying to just make sure that people understand the structure of which we're coming from, I think is important. Next slide, please. What we have is a 2-year program, and this is really around looking at how do we work collaboratively in sharing what we do in England, and in some instances the United Kingdom, in how we've in the past developed the stroke service, the stroke pathway, the stroke workforce, because there has been some challenges, you know, and how do we stimulate some real thought about how we can share some of that with our Indonesian colleagues as well. We have, as Zoe said, and Deb will talk to in a second, you know, we've made significant inroads into the improvements in some of our stroke care, but there's still always work to do. Things are changing. Our population changes. The Indonesian population is massive and will continue to change as well. So how do we continually look to develop service and workforce alongside those changes. And we were really honoured to go to Jakarta in earlier this year to look at, and get a sense check of, okay, so what are we dealing with? How do we work together? We need to immerse and understand what it's like to look at the Jakarta, the Indonesian healthcare system, and Jakarta is a really big city to look at how that functions. And we got a whole load of information, really immersive experience in that space earlier this year, and therefore to set up the second phase, if you like, which is how do we exchange what we do here, we do there, to our experts. I'm not going to stand on ceremony and say I am the expert. Absolutely not. I was there to look at the initial stuff. We're going to bring in the experts going forward. But look at that strategic advice, and how do we start to look at that implementation of exchange going forward as well. Next slide, please. So where are we now? This is one of 3 or more knowledge exchange webinars. So this is the second bit of our year 1 activity, and this is about our Indonesian colleagues providing their context and what do we provide for our context, and that's going to be followed up by a study tour where we will invite the Ministry of Health and National Brain Centre to come to the UK and look at a sort of London, Kent focused look at how it is in the UK in operation going forward. So the other thing is having access to colleagues who are the experts in stroke management, so provide that strategic advice, and actually where there are questions, how do we provide that technical support, and how do we provide that sort of training and education support as well. And then we'll review that year 1 ask at the end, and then into year 2, which will be iterative, which will be dependent on how we've managed year 1. Next slide, please. And a bit of housekeeping. We're all virtual, so there are no fire alarms or no sort of structural based things happening. But we do have an English channel and an Indonesian channel, and they will be available in both languages. And if you can see at the bottom of the screen, for those not familiar to Zoom like me, there are question and answers functions. There's a channel in interpretation to listen to things in each parent language, which I think is really important to get the most out of this. And we've got a chat function as well, which is there for putting in any real-time questions to everybody on the call. But if there's anything specific, you can do that as well. Next slide, please. And over to colleagues from Indonesia. So Eva Susanti, who is going to take the next session. Over to you. Over.
Okay, thank you. Yang saya hormati Bapak, Ibu, terutama Dr. John Cooper dari NHSE Clinical Lead for the Indonesia, NHS England dan Stroke Care Workplace Collaboration. Kemudian Dr. Deborah Lowe, National Clinical Director for Stroke from NHS England. Kemudian Zoe Dayan, Regulatory Reform and Health attached from the British Embassy Jakarta. Kemudian ada Bu Dr. Ita Muharram Sari, Kepala Divisi Neurovascular Rumah Sakit PON. Puji syukur kepada Tuhan Yang Maha Esa yang telah memberikan kita kesempatan ya untuk hadir dalam knowledge exchange webinar tentang overview of stroke service development in Indonesia dan England. Bapak Ibu yang kami hormati, perkenalkan saya Pak Susanti dari Direktorat Penyakit Tidak Menular Kementerian Kesehatan Republik Indonesia. Ada beberapa hal yang kita tahu bahwa jika pada orang pada umumnya waktu time is money, maka bagi pasien stroke time is brain, karena setiap setiap menit ada 1,9 juta sel otak yang mati sejak stroke terjadi. Stroke merupakan penyebab disabilitas nomor 1 dan penyebab kematian nomor 2 di dunia setelah penyakit jantung, baik di negara maju maupun berkembang. Di Indonesia, stroke menjadi penyebab kematian utama, yaitu sekitar 19,42% dari total kematian, dan berdasarkan hasil riskesdas, prevalensi stroke di Indonesia ini meningkat 56% dari 7 per 1000 penduduk pada tahun 2013 menjadi 10,9 per 1000 penduduk pada tahun 2018. Dari sisi pembiayaan, stroke menjadi salah satu penyakit katastrofik dengan pembiayaan terbesar ketiga setelah penyakit jantung dan kanker, yaitu 3,23 triliun rupiah pada tahun 2022. Jumlah ini meningkat jika dibandingkan tahun 2021, yaitu sebesar 1,91 triliun. Hal ini menjadi tantangan dalam pembangunan kesehatan karena stroke berdampak pada menurunnya tingkat produktivitas penduduk Indonesia. Kemudian disabilitas akibat stroke yang menetap atau risiko serangan stroke yang berulang juga cukup tinggi, mengakibatkan pemeliharaan kesehatan individu pasca stroke, menghabiskan pembiayaan yang besar, serta memberikan beban psikologis dan sosial. Sekitar 90% kejadian stroke ini dapat dicegah melalui pengendalian faktor risikonya seperti hipertensi, diabetes, fibrilasi atrium, merokok, kemudian kurang aktivitas fisik, diet yang tidak sehat, dislipidemi, stres, dan konsumsi alkohol. Kementerian Kesehatan melakukan upaya edukasi dan promosi kesehatan untuk meningkatkan pengetahuan dan kesadaran masyarakat dalam rangka pengendalian faktor risiko. Dalam rangka penanggulangan stroke, Kementerian Kesehatan melakukan transformasi kesehatan mulai dari layanan primer hingga teknologi kesehatan, di mana penguatan layanan primer melalui integrasi terutama terkait dengan melalui jejaring ya, pengampuan layanan stroke. Ini dilakukan dengan pemenuhan sarana prasarana serta tenaga kesehatan yang dibutuhkan. Saat ini juga kita mengembangkan precision medicine untuk pasien stroke melalui transformasi teknologi kesehatan berupa whole genome sequencing yang memiliki beberapa hub, salah satunya di Rumah Sakit PON. Saya sangat menyambut baik kegiatan ini sebagai forum untuk knowledge exchange antara Indonesia dan Inggris. Saya mengucap terima kasih kepada British Embassy Jakarta yang telah menyelenggarakan webinar pada hari ini, dan saya mengapresiasi kegiatan ini. Semoga kegiatan ini dapat membuka wawasan bagi kita semua. Saya akan share screen terkait dengan apa yang ingin kami sampaikan untuk update terkait yang penanganan stroke yang ada di Indonesia, di mana ini beberapa data ya terkait dengan dari tahun ke tahun stroke tetap menduduki angka kematian tertinggi yang ada di Indonesia mulai dari tahun 2009 sampai 2019. Kemudian juga kalau kita melihat peningkatan stroke ini trennya juga meningkat gitu ya. Kami sekarang fokus terhadap bagaimana kita melakukan deteksi di awal, terutama bagaimana kita bisa merubah perilaku masyarakat untuk bisa hidup sehat, dan karena memang permasalahan stroke ini sangat merugikan, artinya membebani ya negara Indonesia terkait dengan permasalahan stroke ini. Kemudian juga terkait dengan beberapa permasalahan kesehatan di mana faktor risiko untuk meningkatnya terjadi penyakit tidak menular di Indonesia mulai dari merokok, kemudian aktivitas fisik yang kurang, kemudian juga kurangnya makan buah dan sayur, serta tingginya konsumsi gula, garam, dan lemak. Di mana memang konsumsi gula ini ada sekitar 4,8% masyarakat Indonesia yang mengkonsumsi gula lebih dari 50 gram per hari, kemudian ada sekitar 52,7% yang mengkonsumsi garam lebih dari 2000 gram per hari, dan ada 4,8% yang mengkonsumsi lemak lebih dari 67 gram per hari. Kemudian juga kalau kita melihat terkait bahwa memang Kementerian Kesehatan sedang fokus kepada beberapa transformasi pilar kesehatan.
Some transformation of health in Indonesia. We have 6 of them. The transformation is about how we transform from the primary care or in the service of our primary service is to strengthen the education and also prevention, and also the transformation in the service of extended service in the hospitals. So we have extended service in hospitals in some regions in the local cities or rural area to be able to give a good service in terms of health system. And we have the 4th pillar in which we are doing the transformation of health financing. And the 5th one is the transformation of our workforce. And the 6th one is the technological transformation by making a system, national information system related to the regulation of Ministry of Health number 71 in 2015 about the NCD control, in which we have 4 pillars, 4 main pillars that we are going to strengthen. The first one is to promote health, and then early detection and treatment and rehabilitation. We have to do this interdisciplinary and to be able to do a collaboration again and again. So we want to strengthen how we do prevention toward the risk by having regular health checks, smoking cessation, regular physical activity, healthy diet, get enough rest, and stress management. And then we also have of how we know related to stroke problems, that how we know by we have a jargon of segera ke rumah sakit, which is go to hospital soon. So if you have asymmetrical smile and if you have sudden weakness of half side of the body and dysentery or speech disorder, and if you have half side of body numbness and blurred eye vision and sudden severe headache, we encourage our citizens to go to the hospital directly. So we want to have the early detection, in which the early detection of stroke by related to the checking of lipid profile and such as cholesterol, total cholesterol, HDL, LDL, and triglyceride, and also detection on people with diabetic and hypertension, which are 40 years older, and we want to have of how we do early detection in all group ages, especially in the young ages. We wish them to have some effort to maintain a good and healthy lifestyle, to be able to lowering the risk factor. And then we also have some points related to our problems, is that we are now conducting some efforts for the treatment that we conducted from the primary health care to see the signs and symptoms, and also how we conduct the prevention of risk factors and do some effort in terms of improving them to be able to go to the hospital directly. And we also have 10 priority health problems, in which those 10 health problems, we make a detection starting from the age integrated with the primary service, such as stroke, in which we are strengthening the stratification of our service, of our hospital service, which are hoped to decrease the number of disease and the number of mortality, and to increasing the number of life quality. And then we have, so the hospital that's in charge is the PON hospital, and in terms of rehabilitation, we are conducting physical rehabilitation, cognitive rehabilitation, and psychological rehabilitation. With community-based rehabilitation, we do a home care service to our patients related to the effort to improve the quality of our stroke survivor. I think that's all that I want to present today from the Ministry of Health. We are going to discuss more about the improvement that we can do so we can get the best result, and we know what is the best thing that we can do to improve the quality of stroke care. Thank you.
Thanks for that. That's really helpful. I'd like to introduce Dr. Ita now to take us further forward into stroke medicine from a sort of national perspective as well. So over to you.
Thank you. Thank you very much, Dr. John Cooper. Good afternoon to all participants from Indonesia, and also good morning for all participants from UK. Thank you very much for this kind of opportunity. Today I would like to share about Indonesia stroke service development that focus on secondary care. Maybe slide. Yes, we know from the background that Indonesia is an archipelago country that extends more than 5,000 kilometers from west to east. And we Indonesia divide into 34 provinces. But we know in 2022, we have more provinces, so we have 38 provinces. And also we have more than 500 regencies and more than 70,000 districts. Our total population in 2022 is more than 270 million, but more of the population, more than 50% is population is in Java Island. Okay, slide. For the risk of stroke, we know that every 3 from 1,000 people have a risk of having a stroke per year. So maybe we have almost 800,000 people in Indonesia that have a risk to have stroke in 1 year. About 15% people have a risk of dying, and almost 65% people risk of disability. Slide. Like Dr. Eva said, that we have the stroke, one of the cause the highest death in Indonesia for the last 20 years. Cardiovascular include stroke, have the #1 that the disease cause death in Indonesia, and also for the national coverage system or BPJS, that stroke #3 disease that become the financial burden in Indonesia. Slide. So because of that, we have health system transformation that launched in 2021. We have 6 main pillars from the health system transformation, from the primary care transformation, also secondary care transformation, and also health talent transformation and health technology transformation. For the secondary care transformation, focus in 9 diseases, including 4 major catastrophic disease like the heart disease, stroke, cancer, and also kidney disease. We can mention National Stroke Care Transformation Program or Program Pengampuan Layanan Stroke for the program transformation in stroke. Slide. We know that until now, over that 80% patient is ischemic stroke, and for the ischemic stroke, the definitive treatment is thrombolysis and also thrombectomy. Slide. And more than subarachnoid hemorrhage, we know that the incident is smaller than the ischemic stroke, maybe just 2% of the total of stroke, but the subarachnoid hemorrhage, the patient have a very high risk of rebleeding because the aneurysm. So because of that, so for the patient with subarachnoid hemorrhage, for the treatment, the definitive is we can perform endovascular coiling or maybe surgical clipping for the patient. Slide. Slide. Because of this disease, ischemic stroke and also subarachnoid hemorrhage, so we stratify the stroke-ready hospital become 4 hospital. The first hospital is dasar or basic hospital. For the basic hospital, the hospital only can perform the thrombolysis for the patient. The dasar hospital is located in each regencies or cities in Indonesia. And for the second hospital, we have Madya Hospital. Madya Hospital is also located in each regencies or cities. So the hospital in the Madya, they can perform not only thrombolysis, but also they can perform the vascular intervention non-surgical like mechanical thrombectomy and also endovascular coiling. And for the #3, we have Utama Hospital. Utama Hospital is located in the city or capital of the province. So in Utama Hospital, the hospital also can perform the surgical intervention like the surgical clipping for the patient with the subarachnoid hemorrhage. and also the highest hospital for the acute stroke services, we have Paripurna Hospital. Paripurna Hospital, they can perform that services like Utama Hospital, but they can also provide some guidance for other hospital. Slide. This is the following criteria for the human resource and also the infrastructure for each type of hospital. We know from the Dasar Hospital, they have minimal 1 neurologist, and also they have GP that train for thrombolysis, and also they have stroke trained nurses. For the facilities, they have the head CT scan, minimal 64 slice. And for the Madhya Hospital, they also have minimal 1 neurointerventionist that can perform the non-surgical intervention. For neurointerventionists, they can come from maybe neurologist or maybe radiologist or maybe the neurosurgeon that also they have some additional fellowship. For for Madhya Hospital, also they must have 1 cath lab, minimal 1 cath lab for Madhya Hospital. So for they perform the thrombectomy or maybe the endovascular coiling. And also this is for Utama Hospital. For Utama Hospital, they have minimal 3 neurologists, 1 neurointerventionist, and also they have minimal 1 vascular neurosurgeon, because the neurosurgeon will perform the surgical clipping for the subarachnoid hemorrhage patients. And also for the Paripurna Hospital, they have some kind of the human resource, but we can see also in each hospital, beside the doctor, they must have the nurse. For the Dasar Hospital, minimal have stroke trained nurse, and for Madhya Hospital, they must have stroke trained nurses and also neurointervention trained nurse, and also for Utama Hospital, they must have intraoperative trained nurses. And also we have for the Utama Hospital, they have some facilities like microscope, neurosurgery, or maybe operation room, and the other facilities. For the room for the stroke ward or stroke corner, for the Dasar Hospital, we have for the hospital might have a minimal stroke ward or stroke corner for the observation the patient after the thrombolysis treatment. But in Utama Hospital, the hospital also have a stroke unit or high care unit level, so the monitoring the patient after like the surgical clipping. This is also maybe for the monitoring for each hospital. They also must have a code stroke system. And for Dasar Hospital, we hope they can perform at least 12 cases per year for thrombolysis. For Madhya Hospital, they can perform thrombectomy minimal 6 cases per 1 year, and also coiling 5 cases in 1 year. And also for Utama Hospital, they can perform thrombolysis, thrombectomy, and also 5 cases of surgery clipping. Next slide. For the 34 provinces, because the transformation into 2021, so we have 34 provinces. is divided into 9 regions, and we have 9 paripurna hospital. We can see from the Aceh and also North Sumatra, we have Adam Malik Hospital, and also we have like in West Sumatra, Riau, and also Jambi, we are National Brain Center Hospital and here, and also Banten, also National Brain Center. From the West Java, we have Hasan Sadikin, and also like the East Java, we have Sutomo Hospital, and the Central Java, also Yogyakarta, we have Karyadi Hospital, and we have Wahidin Sudiro Husodo Hospital for the Sulawesi and Papua, and we have Cipto Mangunkusumo Hospital for the Kalimantan. Actually, the national program for stroke care transformation is consists of 570 hospital. So this is just a public or general hospital in Indonesia. But actually our hospital include the private hospital is almost 3,000 and 1,900 hospital. So maybe this program for now until 2027 maybe just will cover for about 20% from the all total hospital in Indonesia. For the vision, this program, the 34 provinces have at least one Utama hospital, and for the each regencies have at least one Madhya hospital. That 50% will achieve in the end of 2023, and hopefully the target 100% in the end of 2027. This is some methods that we will provide for the maybe transformation program on stroke, from the workshop and simulation, telementoring, training, case discussion, or maybe next proctoring, or maybe and it's the important is we must socialization to the government and also local regional health services in its provinces, because we know that in Indonesia we have some decentralisasi, so the every provinces maybe they have our autonomy to health program. Next slide. Okay, next slide. Yeah, this was our background for when we start our national program transformation in stroke. For the human resource, we have 2,200 neurologists that over than 60% neurologists in Java. And for the neurointerventionists, we have 50 neurointerventionists and also just 20 vascular neurosurgeon. And the nurses, stroke training nurses, and also stroke unit is just few hospital that have facilities. And the CT scan or CAT lab not available in each hospital. So for about 570 hospital, maybe we have 65% that maybe have a CT scan. IV thrombolysis might be just 5% hospital that can perform perform thrombolysis from the 2021. And also, I think the biggest problem is the funding from government insurance for stroke is minimal, because more than 95% our patient in public hospital use national government insurance. And for its example, for one patient with the acute ischemic stroke that hospitalized might be for 5 days. For 5 days, the unit cost for treatment might be about 7 until 9 million. So and that include might be all examination and also the drugs. So maybe some hospital consider that treating a stroke patient is not good for the hospital. And also stroke already has not been a priority, and also multi-sector coordination is still minimal, and we see that the public stroke awareness is minimal. Next slide. So we have some coordination and discussion with some professional organization, like from the neurologists and also from neurosurgery or radiologists, and also with Ministry of Health regarding the distribution might be from the human resource, and also how to opening the fellowship. So the fellowship is start opening in the January 2023 for the neuro intervention and also radiology intervention, and also the neurovascular surgeon is start in this January 2023. And also for the Ministry of Health provision of the CT scan or CAT lab equipment for some hospital. And also I think we have some meetings, some discussion, like the other parts might be like with the non-communicable disease to primary stroke prevention, or might be to public stroke awareness. And we also develop an accessible training curriculum for stroke. And also it's very important for nurse stroke training, because I think the nurse stroke training is maybe we need more a number than maybe from the doctor number. So the nurse stroke training is very important. And also from the health transformation, advocacy to national government insurance. So since the February 2023, the IVT drug can be reimbursed. So and also we have top up for thrombectomy and also coiling. So if in 2021 might be the IVT we have in 5% hospital, for 2023 from January until Agustus or until September 2023, we have more increase for the number. We have 7% hospital that perform the thrombolysis for the public hospital. Okay, next slide. We try to create a demographic simulation for each province based on the presence of the Madhya hospital. So this is for each hospital that have CT scan or have CAT lab, and we have some geography that use transportation. We simulation with use car transportation transportation. So we can see maybe example for these two provinces. We have Central Java. Central Java, we know, is the one province in Java Island. that have more than 36 million population. The number 3, the biggest province with the biggest population in Indonesia. And also they have 35 regencies. We see that more the hospital in the Central Java already have the head city and also cath lab. And if we see for the duration transportation, all the patient for the its regencies can perform on to go to Madhya Hospital in below than 3 hours. This is in Central Java. So maybe for the Central Java, because the facilities is already optimal, we can for this province, we for the accelerating for the thrombolysis, we done some workshop and also simulation construct team, and also we increase the stroke trainers. And for the thrombectomy, we for the maybe doctor in the Central Java, we have some fellowship for them, and also neurointervention, nurse training, proctoring, thrombectomy, and also they will have proctoring, coiling, and also flow diverter. Also, we think that in the near 2024, some methods might be drip and drive or drip and ship methods maybe will be performed in the Central Java. But we see in the next province in the Central Sulawesi, it's one province in Sulawesi that have population might be about 3 million. If we can see for the demographic simulation that have more regencies that have not, that they don't have maybe CT scan or maybe have cath lab. So for the regencies in the Central Sulawesi, maybe we have for the thrombolysis, for the CT scan provision and also neurologist distribution is very important for them. And also if they have CT scan or also neurologist, we can perform next workshop and simulation construct. For the thrombectomy, if we will perform thrombectomy in this Central Sulawesi, maybe first we think the red area we must give to the regencies might be first cath lab, and also might be the human resource, and also the fellowship and the nurse training, and the next might be the next we have some proctoring, thrombectomy might be like the in Central Java, but might be the focus of the transformation for the stroke in like in provinces in Indonesia is like individual based on the human resource or might be the facilities in the each province. Next slide. Maybe for the conclusion, stroke is a predominant issue in Indonesia. We know it leading cause of mortality and also accompanied by substantial financial burden. The transformation of stroke service within hospital is being executed through a network mentoring system. Then the improvement focus on the ability to provide stroke service, including thrombolysis, thrombectomy, coiling, and clipping. Thank you very much. We need some suggestion, and maybe my team also will have some join this discussion. Thank you very much.
Thank you so much for that. That's really, really helpful and a good overview of where where we are in Indonesia. And actually, when we hear Deb talking, I think quite a sort of we'll see the differences between the UK and strategy and size as well. And I think that's one of the biggest things here is the size of the problem in Indonesia, isn't it? You know, 270 plus million population, and some of the figures that you've quoted for resource in terms of thrombolysis, thrombectomy, I think would be good for discussion. We've got some questions actually from the webinar, so I'm going to go through those actually before we bring in Deb. So the first one is palliative care for stroke patients in the latest healthcare transformation policy? So that's the first question. And I don't know if you have any insight into that.
Okay.
Ya, terima kasih. Memang perawatan
Thank
paliatif.
you. It is that the palliative care is an important part of intervention towards many diseases, especially for stroke, and also including cancer. So we have done and implementing and make a module of palliative care that we already delivered to the provinces and regencies to be able to do palliative care. However, palliative care is still conducted in hospitals, so it's not yet being given for a community service. I think related towards whether
Okay.
Dokter Ita, mungkin yang terkait
jadi related to the second question, maybe Dr. Ita can explain about the national health insurance from the government, if it is done in the hospital or whether it can be done in the other. Can Dr. Ita answer?
The BPJS finance will cover the procedure if they perform also in type B hospital, but maybe for the intervention like the thrombectomy or the coiling is for now we have a top up cost for the every patient that was in hospital, that treat in hospital. So we have for now it top up cost, not see for the from the type of hospital, but we see for the its patient that treat for the patient.
And that's the second question about BPJS finance. Yeah. And just for UK delegates on the call, palliative in translation is really around the caring and pastoral support rather than what it means in the UK, which would be end of life and a prospect of dying. So I think it's really important to get the context in there as well. So that's about caring, rehabilitation, and life after stroke, I think is how I interpret that. So the third question was regarding the pillars of health transformation in Indonesia. Is the MOH, the Ministry of Health, creating an application that makes it easier for people to get to stroke services as soon as possible? So it's about that accessibility, given the size of and breadth of the problem, of the geography. So is that part of the strategy, access to stroke care?
I try to answer for the application. So maybe if in its province or maybe in its regencies, actually it's if we see in the another country, we have the important like EMS is very important. They can give and also maybe take the patient to the right hospital. Like the example in Indonesia on the EMS is not in every cities or maybe in every province have a good EMS. It is the first. And also about the application, we have try maybe to build the application for the stroke patient so they can choose if they have a stroke sign, maybe go the right hospital. We think we to build that application, but maybe for now the application is not maybe one of our major point for right now for now, but we also maybe build that application for them.
Thanks for that. Next question that's come in, just mindful, we've got a little bit of time.
Menambahkan sedikit jawaban dari Dr.
I'd
Ita.
like to add a little bit on Dr. Ita's answer. We have an application for emergency stage situation in 119 and also for treatment. And 119 is available at every district level in Indonesia. And we also have backup workforce to help out the treatment on the ground so that they can bring the patient directly to the hospital. And for the medicine access for long term, so the drugs or medicine is given for 30 days. And also we do lab tests for other diseases. And at the moment, we have a Sehat Indonesiaku application. In that application, all system will be integrated in this application, including 119 service. It will be included in Sehat Indonesia-ku application. So from this is from medical records and the services that is available at the provincial level and district levels will be all in that one application. Thank you.
Thanks for that. And just a bit on palliative care, there's some comments in the chat function about palliative care and stroke in general requiring interdisciplinary works beyond physician and nurse in terms of rehabilitation, and how would we improve its inclusion. So when we did our visit in July, we looked at the cadres, you know, as a really interesting group of individuals who, you know, certainly in the districts and so in the villages could actually provide some of that through a very reasonably quick cross-skill upskill, but I think it goes beyond the sort of secondary care model. You know, it's into the primary care element to it, so it's something to think about. Right. Mindful of time, where's my clock? There it is. Prevention of complications as the biggest opportunity to improve outcomes post-stroke. And what is, and so it links into that comment really, what is that plan for upskilling the whole of the multidisciplinary team, particularly nurses, in delivering high quality care? So this is about the workforce again and how we skill up the workforce in that stroke or neuro or disability space. Does anyone have any comments on that? So that's question 4. It's prevention of complications. So one of the biggest challenges we see in the UK is life after stroke. It's after the after discharge, after going home, and 25% or so of our stroke patients are of working age. But even when you're not of working age, it's the impact of post-stroke complications and disability.
Terima kasih. Jadi
Thank
memang
you
terkait dengan perawatan pasca stroke,
for the post-stroke care.
apa namanya, sebenarnya sudah ada konsep rehabilitasi
Actually, we
berbasis
have already got the community-based rehabilitation concept. So this community-based rehabilitation concept,
jadi persoalannya. Pertama,
we still face some challenges. One is the lack of health workers. So that means the distribution and the number of health workers are not adequate, especially for the remote areas. And also, we have a second problem, which is this community-based rehabilitation concept. For example, it's still not paid or covered by BPJS. So they don't cover actually for this service. So that's why that we are still having a problem on this. We've tried to collaborate with the academies
untuk bisa menjadi basis rehabilitasi berbasis masyarakat ini. Jadi kami mengharapkan
so that they can do this. So we hope that there will be a pilot project for the RBM that can be initiated by the health polytechnics or health academies, so that the students who will complete their study can help out in doing this rehabilitation on the post-stroke patients. But we are trying this out in one district, but this has not been replicated in other districts because BPJS are still not covering for this activity. Thank you.
Thanks for that. That's really helpful. So there's a lot of issues around insurance, finance, and buy-in there. So, and I think the other thing that I from the visit and some work that we'll be doing going forward is looking at that training model and the very academic based approach to training, which you know, maybe something to explore further, but has a larger implication on how you train, because I think the UK model is very, very different to the Indonesian model, and that's a cultural change which takes a bit of time, but I think is not not out of scope. Okay, in the interest of time, the question for Deb and I about thrombectomy and thrombolysis, I think will be best covered after Deb's talk, and skill maintenance and skill decay, which again is a really important bit of how we look at things. And I think looking at the sheer numbers of with a population that is close to 68 million going forward into the next year, versus 270 million. And actually the numbers that we actually target, which has been a major driver, I think, in the changes to stroke outcomes in the last 20 years or so. So I think this is a good opportunity to introduce Deb Lowe, who is a good friend of mine in a very small world of stroke. I say that tongue in cheek, of course. I've worked with Deb in the past, many years ago, and we cross paths a lot in the stroke space, if you like. Deb is National Clinical Director for Stroke and a Senior Advisor for GIRFT, getting it right first time. And these are structures that the NHS has put in place to look at the service and move it forward, and is a practicing consultant in Merseyside near Liverpool, on the Wirral in England. So still practicing and knows what it's like on the ground. So Deb, over to you for your presentation. Thank you very much.
Thank you. Selamat pagi. It's a real honour to speak this morning or this afternoon to you all, and really delighted to be part of this programme. So, next slide. Within England, we, although a lot of work has been done to focus on improving the care for people suffering from stroke and their rehabilitation, stroke is still the leading cause of disability for adults in England and the 4th largest cause of death in the UK. We have approximately 100,000 strokes per year in the UK. By the UK, obviously, I'm including Scotland, Wales, and Northern Ireland. And 50% of our stroke survivors are left with a disability, whether physical, communication, cognitive, or psychological, and not forgetting the huge burden of fatigue post-stroke. Stroke currently costs the UK economy about £26 billion per year. And we know that this is likely to increase to 91 billion by 2035. And this is mostly due to what we refer to as the baby boom generation. So people will be turning 65 over the next 20 years. We know that stroke indiscriminately affects those living in poorer or deprived social housing conditions. And we also know that people with multimorbidity or comorbidity are more likely to have stroke and live with stroke symptoms. Next slide. Cerebrovascular disease causes 1 in 4 deaths in the UK, and within that, stroke causes a death every 17 minutes. Next slide. As I've just mentioned, we know when we look at the index of medical deprivation, if you are in one of the most deprived quintiles, you are 4 times more likely to die before the age of 60 from stroke. And 25% of all strokes happen in those under 65 in England. Next. We have had some success. So over the last, well, just under 30 years, so 25 years, we've seen a 50% reduction in mortality from stroke. Next slide. We've also seen almost a 50% reduction in the length of stay for people staying in hospital following their stroke. And this has been mostly due to a focus on organised stroke care within stroke units in English hospitals. Next. This mortality reduction, however, in the last 10 years has significantly slowed down. And one might say this might be expected based on a finite reduction that we might have seen in hospital mortality. Next slide. But we also know that when we look at CVD mortality improvement across heart disease, so CHD, and stroke in the darker grey, this has also slowed down. And this is extremely worrying on a population health level. Next. So because of this, in 2019, the government and the Department of Health and Social Care agreed that stroke should be a priority within England. And the publication of the NHS long-term plan included stroke and a focus on the end-to-end pathway, including prevention, acute treatment in hospitals, access to thrombolysis and thrombectomy, and an improvement in high-intensity models of rehabilitation, both in the hospital and at home. Next slide. This ran in parallel with a quality improvement programme called GIRFT, Getting It Right First Time, which involved myself and a colleague, Dr. David Hargroves, visiting every single stroke unit and team in the country, that's over 120 services, over an 18-month period, and giving them recommendations against national clinical guidelines to deliver the end-to-end pathway approach. And this included leadership, culture, and driving stroke networks. This is available on the web address below. Next slide. We also developed the NHS England National Stroke Programme, which I'm the National Clinical Director for, and we have a National Stroke Delivery Board that is chaired by myself and the Chief Executive of our main charity, the Stroke Association, and that's Juliette Bouverie. We have a very clear governance structure and we report directly up to the National CVD, Cerebral Vascular Disease and Respiratory Board, and that's chaired by Professor Sir Steve Powis, who is the Medical Director for NHS England. We have several work streams within the stroke programme as listed on the slide. Next slide. We were very clear that we wanted to have a structure and a framework for the delivery of stroke care, so there was less variation across the country. And to do this, we developed the National Stroke Service Model, which is a policy document that describes the requirements for clinicians and commissioners to deliver the end-to-end pathway. Next slide. We set up 20 stroke delivery networks, similar to the networks that Dr. Eva and Dr. Itta have described across the country. Within each of the networks, there are referring hubs into our 24 neurosciences centres, and we have 120 acute stroke centres across the country. Next slide. I've spoken about the end-to-end pathway approach. We knew from work that had happened in London and Greater Manchester how important it was not just to redesign the acute pathway, but to tackle prevention, urgent care and rehabilitation, and most importantly, life after stroke support when we're looking at quality improvement across the pathway, because doing one without the other meant that there were significant problems in discharging people from acute hospitals without the necessary needs-based rehabilitation. Next slide. We're very lucky that we've got comprehensive national clinical guidelines for stroke, again, to reduce the variation. Our last iteration of this, we've had 6 editions, but this was published in April this year. And this was a 5 nations approach, so across the United Kingdom and the Republic of Ireland, and again looks at the end-to-end pathway, including vocational rehabilitation and psychological support. And this is based on clear published evidence and peer review. In areas where we didn't have the information that we needed in terms of randomized controlled trials, there was a pragmatic clinical consensus guideline published. Next slide. These guidelines are available for all clinicians working across the stroke pathway. They're also in easy access publication for our stroke survivors and their carers, and they're also available via an online app. Next slide. We're also very privileged to have one of the most globally recognised data sets for stroke. Our national SNAP audit collects over 400 specific performance indicators across the stroke pathway. This means that stroke teams can understand their performance minute to minute across their stroke pathway. And these data sets are all publicly accessible approximately 3 months after the data has been collected. This has been running for 25 years, and we last had a big update of our data set in 2013. But this data set is commissioned by the National Stroke Programme and NHS England. Next slide. We also have the CVD Prevent audit, and this means that we can assess how our primary care services are delivering care against management of blood pressure, atrial fibrillation and hypertension. This data is all publicly accessible. Next slide. We have very clear public health and now OHID ambitions. That's the Office of Health and Innovation Disparities. And the targets on the screen are those around the ABC of preventing stroke. Next slide. The data from the CVD Prevent audit is published every quarter, and we can understand how our general practitioners who provide primary and secondary prevention support across the country are performing against key metrics. This is available for hypertension and also atrial fibrillation and high cholesterol. And it also gives us an idea of the inequalities data also. Next slide. We are really focused within NHS England on making sure that we are digitally enabled to deliver the stroke pathway. And there's been a real focus on that when we have large geographical areas that we need to support digitally. Next slide. A couple of the areas we've been focusing on over the last couple of years have been tele-hospital triage, so that a stroke team, a paramedic ambulance team, can see the stroke patient and speak to a stroke doctor at the stroke centre across the country for a rapid early decision. Next slide. This has been extremely successful, and we're currently running 15 pilot sites across the country. It's resulted in decreased transferring of patients that clearly are not having strokes, but also it's increased the rapid transfer of patients to stroke centres that are clearly having major large vessel occlusion strokes. Next slide. We've been focusing also on a national optimal stroke imaging pathway. All of our stroke centres have access to CT and MRI scanning, but not all have MRI scanning 24/7, and certainly not all have access to scanning to MRI as first line if needed. We also have a pathway that ensures straight to CT and CTA, so CT angiogram, for patients that might be accessible for thrombectomy. Next slide. We've had a plan, sorry about the complicated slide, we've had a plan of implementation for AI, so artificial intelligence, to help people at the acute stroke centres interpret and make decisions around how appropriate it is to give thrombolysis or thrombectomy. We had 8% of units accessing AI at the start of the long-term plan, and now that's up to 95%. Next slide. So I'm just going to talk briefly about thrombectomy. Next slide. We have a very clear governance structure to try and improve the delivery of thrombectomy. We are not where we need to be in this country for the delivery of thrombectomy, but we have a very clear structure now that means that our 7 regions across the country report back to a national thrombectomy implementation group. Next slide. We've carried out regional quality reviews, and we have 6 communities of practice across the country where we bring our thrombectomy centres together to work together. So the good centres that are very high in their percentage of delivery are working collectively with those that are not, and we can learn from each other. Next slide. This resulted just over a month ago in a mechanical thrombectomy webinar that again is available on the website below, and a national thrombectomy report that focused on quality improvement areas. Next slide. We've been focusing on not only pre-hospital, but what happens at the acute centre and the comprehensive stroke centre. We've also been looking at repatriation. So how do we return the stroke survivor post-thrombectomy back to the acute stroke centre? Next slide. We've identified 9 key steps in what we call DIDO, door in, door out time, because time is brain when delivering recanalisation therapies. We have a lot of data on this from our national survey and national audit. Next slide. So what's our data set telling us about thrombectomy? Next slide. So in England, in the last couple of years, we've seen a 25% increase in access to thrombectomy. There have been over 11,000 thrombectomies conducted, and there were just under 3,500 conducted in 2022. We know you're more likely to get thrombectomy if you present directly to the Comprehensive Stroke Centre than if you present to the Acute Stroke Centre. Next slide. We know in great levels of detail the percentage thrombectomy rates across the countries and also within each region. In London currently, 10% of all stroke patients receive a thrombectomy, and this is much lower in other parts of the country. Next slide. We have thrombectomy networks, and we know how many are delivered at each of the centres across the country. As you can see, in east of England, there is not the same delivery of thrombectomy, and people have to travel often down to London or long distances to receive thrombectomy. Next slide. We do have a shortage of interventional neuroradiologists, but within England we have it looks like many more than you have within Indonesia. We've currently got approximately 150 thrombectomists either practicing or in training across the country. We've also just created a credential, which means that non-INRs can train to deliver thrombectomy. And we've got a few neurosurgeons and interventional radiologists. Next slide. Next slide. We've got a real focus on at the moment on the delivery of thrombolysis with a target of 20% delivery. Next slide. It's currently in this country delivered at approximately 12%, but some centres are much higher than this, closer to 25%. Next slide. Next slide. Our quality improvement programme uses data from the National SNAP audit to look at hospital processes, time to delivery of thrombolysis, and also looks at individual clinical behaviours that might result in thrombolysis not being delivered. Next slide. We know that we've got data on over, well, just under 250,000 stroke admissions with over 26,000 thrombolyzed cases. And we're looking at what the variation is and why this might happen. Next slide. We know that the highly performing centres for thrombolysis can help the more lower performing centres, and we're expecting to get to an approximate 16% thrombolysis rate, hopefully within the next 18 months. Next slide. So focusing really importantly now for the next few minutes on rehabilitation, life after stroke. We've published the Integrated Community Stroke Service Model alongside our National Stroke Service Model. This is all available on the NHS England website. Next slide. The real focus is that we have a needs-based, not a time-based delivery of rehabilitation, and this is delivered when the patient is ready in the community, in their own home, not in the hospital. We've also got a really key focus on vocational rehabilitation, psychological support, and return to living. Next slide. We've got a really clear evidence base that rehabilitation works, and this has been published within our national clinical guidelines. Next slide. And we've got a real focus on intensity of rehabilitation. We have 7 regional experts. They are therapists that work across the regions to support the delivery of the Integrated Community Stroke Service Model. Next slide. We've had stroke pilots that have proved that this pathway can be delivered across different parts of the country, so the capital in London, but also more rural areas in Northumbria and Northampton. We funded over £15 million into the Stroke Catalyst projects to demonstrate how we can improve stroke quality improvement pathways for rehabilitation. Next slide. The projects that we've been looking at and funding have been looking at the following areas that are listed. So how we review people post-stroke and ensure that they're taking appropriate steps to prevention, speech and language therapy, and also, rather importantly, perhaps for Indonesia, technology and the delivery of virtual rehabilitation. Next slide. All of the work that's been done within these projects is available again. I'm sure these slides will be shared, but on these embedded links on the slide. Next slide. We've also, within England, just completed the first ever national patient-reported experience measures survey in 22-23. There was 100% completion and involvement from our stroke units, and over 6,500 stroke survivors completed the questionnaire that told them and told us as a national health service how we were doing, what the patient experience was for the delivery of stroke care. Next slide. This again is all available publicly on the SNAP website and at stroke.org.uk. Our stroke teams across the country are using this information to understand how they can deliver quality improvement for their stroke pathway. Next slide. Really importantly, we've got our new NHS long-term workforce plan published in June 2023. We do not have the workforce that we need currently to deliver the end-to-end stroke pathway. That includes interventional neuroradiologists, it includes stroke physicians, our specialist stroke nurses and our therapy workforce. But we're hopeful within the framework, within the long-term plan, that this can be improved upon. And it needs to be improved upon because we know that however good we are at prevention, we're still expecting a 50% increase in the number of people that have strokes in the next 20 to 30 years. Next slide. We also are training our next group of leaders in stroke, and we're working with the King's Fund and the Royal College of Physicians to train a multidisciplinary group of people. We've had 28 people this year to be able to lead our stroke services across the country, and it's really, really important that we focus on our leaders. And it's important that these are not all doctors, these are nurses, therapists and ops managers. Next slide. I'm going to leave it there. Thank you very much indeed. Terima kasih.
Thanks, Deb. Really good run through of the UK perspective on stroke, and having been part of it for however long, we have seen those changes, but we've seen the challenges along the way as well. So thank you for that. And I think what I've seen today is that contrast between countries, not just in population size, but in how things are done. And sometimes, I suppose, when you've got a compact country like the UK with a population a third of the size of Indonesia, it might be a little bit easier to do things, perhaps. Whereas you describe, when I look at Indonesia, I look at something from the UK across to Turkey in Europe, in terms of the geographical spread. That's massive. It's massive. And the timescales offered by the ministry are to me are quite a challenge. So I'm going to go through some of the questions again. I think we're at 9:35. I think we've got 20 minutes or so for questions here. And let's work through. I'm going to go on thumbs up first. So how many types of healthcare workforce in the UK have got capabilities or competencies in handling stroke care, from prevention on the primary care until the medical care in the referral hospital? How do you conduct healthcare workforce planning for each type of healthcare workforce and calculate projection to meet the need of stroke nationally? So I might try and answer that one, actually. So workforce calculations historically have been, I would probably say, try to be calculated on a national scale, probably not correctly, and just about, and probably underestimated. We've got some really good the need. So in terms of stroke, you know, what is our future stroke rate? And what we will do, I think our next webinar will be dedicated to that, and bringing in colleagues from workforce planning and population health. I think will be really important to see what you can do with data, because what we do know, and Deb alluded to in her talk, you've got to know about the past before you can work about the future. And we know that in the late 40s, 50s, we had a big explosion of population post World War II. And then we introduced the oral contraceptive pill, we introduced the Abortion Act, and then the population started to decline. So we've got our 60s and 70s and 80s population coming in the next decade, 2 decades. So we know what our population is going to be. We know our birth rates as well. So we know that as a country, we are a less productive country in terms of birth rates, apart from Birmingham to London. That's the only bit that is going to increase in its birth rates. So our population in general is going to get older. Stroke is predominantly, not exclusively, but predominantly a disease of older age. And we know that healthcare consumption of 70-year-old, 80-year-old and 90-year-old doubles with time. In our aging population, we're going to have about 1 million extra people in their 90s in the next decade and a half or so. And they will consume twice as much healthcare as somebody in their 80s. So we know we're going to need a workforce that can deal with that population of people. And so we work around how we calculate that going forward. There is a complex methodology we have in NHS England as well. However, Deb also alluded to the long-term workforce plan, which is almost a refresh of workforce within the United Kingdom, within England, and that is about big numbers, not just medics, but multi-professional colleagues, allied healthcare professionals, nursing, allied professionals as well, which is going to be really important. But I think what we do need to do is calculate that on a regional level. So we know what London might need. We know what Merseyside might need. We know what Yorkshire and the Humber and the North might need based on their population health. And that's how we're going to do things going forward. So it is a refresh of how we've done things historically. And I'll come back to the fact that I think we will dedicate the next webinar on workforce and population health, which I think will be really important, because I think whatever we do in the United Kingdom, certainly in England, I think the task in Indonesia is even more massive. And even if we start somewhere, it's getting you to think, as a country differently about how you might approach workforce. I don't know if Deb or anyone else on the panel, if anyone else wants to comment on that. If not, I'm happy to move forward. So the next question I had was one for Deb. So, dear Deborah Lowe, we don't have a step-down care or rehabilitation unit for stroke patients before discharge from acute hospital. Usually even patients are allowed to be discharged by the doctor, but the family isn't ready to take the stroke care at home. How do you manage stroke patients in the community, and how do you prepare the family for taking them home?
Thank you, John. Thank you for the question. Certainly, within most of our 120 acute stroke centres, we have a very multidisciplinary approach. So from the minute our stroke patients have had the diagnosis and start their rehabilitation while they're in hospital, so we have a standard that our stroke survivors are seen by a physio or occupational therapist or speech therapist within 24 hours if required. And we have what we call multidisciplinary team meetings very early and often daily. and we will have conversations and family meetings very early to make sure that we're communicating efficiently and effectively. If patients can transfer with one therapist or carer, and we think they can be managed within the early supported discharge team, that means that the minute that they go home, they start to receive therapy as they get to their own home. And we aim that that is at a similar level to what you'd receive in hospital. That's still not enough in this country, but we are working very closely to improve that. We have probably about 15% of our stroke patients will remain in hospital in what we call a step down or inpatient rehabilitation bed if they're not able to transfer with one or have significant needs or no one to care for them at home, and they'll stay in hospital a little bit longer. But certainly within our early supported discharge pathway, I think the key to the rapid discharge is that early multidisciplinary team communication that we have. We do know as well that approximately 1/3 of our major strokes, so our total anterior circulation strokes, do often require 24/7 nursing or residential home care. But with the new integrated community stroke service model, they can continue to receive rehabilitation even when they're discharged to care homes. I hope that answers the question, John.
Thanks. Yeah. That's really helpful, actually. And I think, again, it's for me, it's a little bit about size, isn't it? I think, which is the challenge. So on challenges, as well as sharing good practice or approach, particularly in the less resourced or deprived areas of the country, which with less accessible to stroke care in the community, how do we tackle the multi-ethnic community in the UK? And I think Deb's probably answered that in the last question. I think this is around about equity and equality to access in terms of rolling out stroke. So it is everybody's business in every region within both England and all the 4 nations, because I think it's important to say that it's trying to roll things out so that there is equitable access to stroke care and rehabilitation across the whole pathway. One of the things, and again, I'm going to come back to this, I think the bits that are filtering through from a question perspective is around palliative care or community care or life after stroke in Indonesia, and accessibility to those areas. And I think, having done the technical visit back in July and seeing a very busy urban or busy city healthcare system, I totally appreciate that. The remote and rural areas of Indonesia are a massive might have a massive deficit in terms of access, and it's then how do we refocus and reframe how a part of that training, skilling, upskilling to a community of people who are involved in prevention, involved in palliative care. And I come back to the hamlets, the villages, and I'm going to call them colleagues as cadres, who have a real opportunity to look at how that might be able to provide some of the care associated with it. Okay, let's look on to another question here. So again, Deb, so in the UK, we've got an outstanding program for stroke, and I wouldn't disagree with that. I think in principle, what we structured in stroke has been pretty impressive in terms, and we've got evidence of outcomes that can show that in terms of mortality in the first instance. How do you think, what do you think about what you've heard about Indonesia, and do you have any suggestions? I'm putting you on the spot, actually. That's a really tough question to answer, bearing in mind, the political and cultural sensitivity. But I think it's really important to be open here, because what I want from this collaboration, I think, and what the team wants is honesty, and how can we make a difference for Indonesian stroke care? And that's the aim of this. That's the primary objective.
Thank you. I mean, I was incredibly impressed by Dr. Ava and Dr. Issa's presentation, and the challenges on such a huge population base is just staggering, and almost so overwhelming. In my head, I was thinking, goodness, I can't imagine if the challenges were quite as diverse and geographically challenging as it is currently in Indonesia. But I think, from my perspective, coming into this role, on a national leadership role over the last 7 years, I think the key things have been around networks, so making this into small enough areas that quality improvement can be done at a much smaller scale. The importance of leadership within those networks and having a clear voice, and basing that leadership around a data set of what we should be doing against national guidelines, so everyone has a very clear framework. And I think doing quality improvement around a national data set and national guideline is gives everyone something to aim for, and it also introduces a little bit of competition between units, which is often quite helpful. I think having communities of practice, regular meetings where you're hearing what some people are doing in one unit and others, that shared learning, so people don't feel like they're doing it alone. So nothing super clever, nothing super expensive, but creating those communities and that level of communication. And then I think separately around prevention, I was really impressed with Dr. Etta's description about some of the work that's happening around prevention. We haven't got it right. We're certainly very clear within England that we are experiencing a massive increase in obesity, type 2 diabetes. Smoking rates are going down for men, but haven't gone down as quickly for women. We know that cholesterol management isn't where it needs to be. But again, we're very privileged as a National Health Service that even in areas that are more deprived, or there are more inequalities, everyone has access to a general practitioner. So supporting our primary care, which is where 90% of all of our healthcare takes place, is really, really important. And I think the focus on a data set that helps our general practitioners understand how to deliver that primary and secondary prevention and how they're doing is really vital. Thanks, John.
Thanks for that. I think that's it. And again, it's for me, it's stepping outside the UK model and look at what is transferable. And I think it is about building blocks of breaking it down into different smaller bits of how, I don't think you can transform the entirety of Indonesian stroke healthcare in a day, and the timescales, I think, I totally appreciate are ministerially delivered, but are a major challenge. But let's look at what we can offer in terms of the next few months, certainly with the webinar exchanges and the reciprocal technical visit in January to look at how you can just take home something that might actually make a difference going forward. Okay, so I've lost my messages. Here we are. So we've got one for Dr. Eva and Dr. Itza again. It's an earlier question. It seems like palliative care has not been accommodated in the stroke strategy or management, whereas stroke is evident to be life-threatening in Indonesia. What's the next plan to align it in future program and service across level, so home, primary, secondary, and tertiary level? And then there's a second add-on question with that. And again, palliative care in stroke requires interdisciplinary work beyond the physician and the nurse, which I agree with. And how would Indonesia improve that inclusion? And there's a third element to that question. And how would we more meaningfully engage with stroke survivor and the patient group? in stroke policy, budget, programme and service development. So 3 questions in one, a lot of stuff to unpackage there for Dr. Eva and Dr. Itta.
Terima kasih. Jadi
Yes,
memang
thank you very much. So we already have a corporation with stroke survivors in Indonesia. We have 2 foundations of Stroke Foundation, which is Strokey and Stroker. We have Strokey, the foundation has help related to the effort of the governance of stroke survivor and patients, and to give them trainings and then living helps. And also with the second foundation, they help us by giving information, educative information to the citizens about how the stroke problems related with economic, psychology, and also related to the networks within stroke survivors and patients to support each other in to support them to have a community activity around the stroke survivors. So we had a program in the stroke day. We give them understanding about our effort to prevent stroke, especially about the lifestyle, towards the healthy lifestyle. Within some jargons, we have a regulation from the president to make the people have a healthy lifestyle with the presidential instruction number 1 in 2017, in which in the policy it was stated that the way to manage the disease must be done multidisciplinary within the community, within the organization, with the private organization, and then also religion leaders to manage the stroke better in the future. Thank you. Dr. Ita can add some more.
Thank you. Maybe for the actually for the secondary care of transformation, for now we still focus on acute or hyperacute stroke treatment. Thank you very much. I think we like Dr. Eva said, we will maybe in the next step include some the next for the secondary prevention, or maybe for the home palliative for the treatment focus on the next also for the stroke patient. We have maybe more discussion or maybe more meeting for the next focus on secondary stroke care, but also hopefully in the next year for the next program for the stroke care is more comprehensive for that. Thank you.
Thanks for that. And I know in the technical visit going forward in the new year, we have prevention included in that, and it may be that we look at that in a bit more detail going forward. So fantastic, thank you. Okay, I think we're coming up to in UK time sort of 5 to 10, and in Indonesian time 5 to 5. So it's technically the end of the working day for some. Actually, it's not in medicine, is it? It goes on forever. So what I'd like to say, I think this has been really helpful. And I want to thank Dr. Eva, Dr. Itta, and Deb as well for their presentations today. What I've seen is there is a real interest in making this work within Indonesia. And looking at the comments in the chat, Ratner had posted a chat about stroke community, and I just wanted to reflect on that a little bit, because I think we saw that when we did our STAR workshop in Indonesia, bringing together a community of practice, a bunch of individuals who may not have met before or worked together before, but had a common goal. And I think that that was really important. And that was, how do we make stroke services in Jakarta focused, but how do we make that better? And that was really evident at that point. And that sense of community, I think, is something to go away with. And how do we connect everyone up together? It's back to networks and community, I think, for us, as we've done in the UK. And that might be the starting point as well for making services and pathways work well. So I would like to look at drawing the webinar today to a close. And I don't know if the panel have got any final comments. I realize I've hogged the limelight here, but Deb, Dr. Eva, Dr. Anything from you guys as well, as a closing remark?
Only really from me, John, just that we, wherever we come from, we are stronger when we work together and share ideas than when we work in silos or individually. So it's an exciting time to, all work together, because things are changing within cerebrovascular disease. Thank you.
Yeah, I agree. And the end point is always the same, isn't it? It is stroke here. And I think global health is really important. I think the concept of global health is, that's why we're here. I think there's a lot of sharing that we can do, both from a knowledge and structural perspective, but also to a physical perspective going forward. Not quite sure where we are at the moment for that, but I think that there's further collaboration in the future. So everyone on the Zoom call, everyone on the panel, thank you very much, and take care, and we'll see you for the next webinar too. Brilliant.
Thank you.
Bye now.
Thank you very much. Bye.
You're welcome. Take care, everyone. Bye.
Bye.
Ya, thank you. Terima kasih untuk Dr. John, Dr. Deb, atas sharing informasinya. Semoga nanti kita bisa.
Thank you to Dr. John and Dr. Deb for the information sharing. Hopefully, we can have a more intensive collaboration and also to upscale our skills so that we can actually improve our stroke handling. Thank you.
Great.
You're
Thank you
welcome.
very much. Thank you.
Take care.
Bye-bye.